Welcome to Emergency Medicine Academy podcast, where we explore key issues faced by emergency clinicians. In today's episode, we are going to discuss Do Not Resuscitate orders, a complex and often sensitive topic in the emergency medicine. We are going to look at the principles behind DNR decisions, the challenges of making them in time-critical situations, and how to approach these conversations with compassion, clarity, and professionalism. This is Muhammad Fagir, one of the co-founders and instructors of Emergency Medicine Academy, and I'm glad to introduce my colleague
Hassan Abdurrahman, co-founder and instructor of the Emergency Medicine Academy, and it is a pleasure to have a discussion about this very important topic today.
Welcome, Hassan. So without further ado, let us start our conversation. So can you tell me about DNR? What's DNR?
So DNR stands for Do Not Resuscitate, and some people using another terms like DNA, CPR, do not attempt cardiopulmonary resuscitation. So this is a decision to be made in the emergency department or in the critical care settings. Sometimes we're doing it for admitted patients. And we're going to talk in details about the DNA CPR today. And yeah.
All right. Okay. So let me give you a scenario, and then we'll take it from there. You are working in the emergency department. You are the most senior doctor, and you received an alert that an 83-year-old gentleman is gonna be brought to your department in 5 minutes with low GCS of 3, and his tachy around 140, and oxygen saturation in room air like 60%. He's on high flow oxygen. So what's your thoughts?
Yeah, so this is very sick patient, and this is will be a very challenging situation for the emergency department, and particularly for us working in as ED doctors. We are facing such patients with critical vital signs, and those patients will be brought shortly to our ED. So we need to prepare ourselves. We need to prepare our mind, and we need to keep the decision of do not resuscitate in the back of our mind, and we need to prepare mentally and as well clinically to assess the patient properly and to weigh the situation of the patient, and based on that we can come to the decision. We can go in which way. Is it for full resuscitation, or we need to initiate that decision of do not attempt resuscitation as soon as possible.
Right.
It is very quite challenging, and most physicians find it very difficult to make a decision rapidly while the patient in the resuscitation room. And the challenging as well, because we need to do two things now. This patient is quite sick and quite desaturating, and looks like his vital sign is quite not well. GCS is low. And what things needs to be done first? Is it the resuscitation, initial phases of the resuscitation, or to jump to that decision? And plus, for this patient, we got pre-alert. Usually in the pre-alert situation, we don't have any medical backgrounds or records which can tell us the condition of the patient. So it is quite challenging situation. But we're going to address these challenges as we're going through.
All right. Yeah. So let's say that the patient arrived, you started your resuscitation, the A, B, C, D, E, and everything. We're not going to talk about the resuscitation today. However, after your initial resuscitation, you provided everything needed to be done at that time. Now you are considering whether this patient is for like full escalation or not. So what are the initial things we need to do?
So as the initial phase of the resuscitation is already started, and at least I can stabilize the patient to the level that I will have a chance to look for the records. So what those things which tell us that we might go to decision of do not resuscitate, or we can apply the full resuscitation for the patient. So those are the background of the patient in terms of the medical background. So we need to check the comorbidities of the patient, like heart failure, presence of heart failure, renal impairment, and the level of awareness of the patient generally. And as well, we need to check the frailty level of the patient. And age as well is playing a big role in this decision. And before this, I think there is one single question you need to ask yourself before doing this decision, which is, would I be surprised if this patient died within the next year or less than that? So this is also a very important question, and it will help you to determine which pathway you are going to follow. So again, I'm going to check the comorbidities of the patient. I'm going to check the age and the current status and previous hospital admission. I mean by that the frequency of admission. If I notice that in the medical record that this patient had a frequent attendance to the ED with infection, and I'm also going to check the frailty score. Is it increasing very rapidly? Plus, now in this scenario, you mentioned that this patient is either delirious because of the infection itself or because of the medical illness, or it might be something going in the brain. So also I need to check the level of awareness of the patient before coming to the hospital and check for deterioration. So there are many factors. We need to put them into consideration before uh, taking this decision.
All right. Okay. So let's say that um, actually you tried to check in the hospital records and you couldn't find any previous records for any reason. Who else we can contact apart from talking to the patient himself? Obviously, we need to talk to the patient if he's oriented and establish these facts. But if the patient is, as you said, probably delirious for any reason or confused, and there is no other notes to check, is there any other parties we can contact to get this or this collateral history?
Yes, definitely. Yes. So this is added more challenging to the situation uh, in case if there is no records in the system. So at this situation, we need to contact the registered next of kin and ask them about the condition of the patient. As long as the patient is not uh, maintaining his mentation. So next of kin, if the patient came from nursing home, we can contact the nursing home, asking the team who was taking care of the patient before arriving to the ED about the general condition, about the comorbidities, about the frailty score, and this will give us an idea about which direction we're heading. So next of kin or any carers, or if the patient came from the nursing home, we can just like make or try to take more collateral history. And this is at least will give us a clue about what's going on and the medical background of the patient.
All right. Okay. Yeah, that's fair. And I have a question regarding the difference between DNR and respect form. I know that in different trusts they use different forms. In some hospitals they use the DNR form, and other hospitals and they actually use the respect form. So can you tell me what's the difference?
Yeah, so the patients coming to the ED, sometimes they already had a respect form. So a respect form, this is a form for which we're doing it in the hospital to tell us what type of escalation of the care the patient can get from their visit in the ED. For example, ward based admission, or the patient had uh, a decision made before in the previous visit that he had a DNR or do not resuscitate status in the form. So most of the patients, or the majority of them, when they're being brought to the ED by paramedics, usually they have this form in place. But we are talking about the people who don't have the form with them. So the respect form, this is a form which we are doing it in the hospital, which it is the same as a DNR. Yes, so that's the general condition about the respect form.
Yeah, yeah. And I think the respect form and the DNR forms, both of them can be done in the hospital or in the community. Sometimes the GPs might have these conversations with the patients when they are in a good condition, but they discuss with them the future if their situation or medical condition deteriorated to the point that their heart stopped, or if to determine the level of treatment and management that they should have. Is that right?
Yes, that's correct. It is a form of advanced decision. Sometimes can be
Yeah.
included in the respect form. I totally agree with the things which you said just now. That the decision might be done not in the hospital and sometimes in the community or by the GP. So respect form, it is stand for recommended summary plan for emergency care and treatment.
Yeah.
So yeah, definitely it can be done in advance before the patient coming or before the patient had this illness which make them their level of awareness and their level of orientation became disrupted. At that time, they had a full capacity and they had a chat with a healthcare provider, and they came to the decision that they might not wish to have a chest compression done for them.
Yeah. And I think also the respect form, it better addresses the ceilings of care for the patient more than the DNR form, because the DNR form is just in the situation if the heart stopped, but the respect addresses the ceilings of care and whether the patient for only ward level care or for level 2 or 3 where he might go to intensive care. That's my understanding.
Yes, in different words, I think respect form is more broader than the decision of the DNR itself. And here I want to highlight another point uh, about the DNR and the patient who's going to die, the palliative care.
Yeah.
So the decision of DNR, for example, the same patient which you gave in the initial scenario, that if me as a physician, I came to the decision that this patient might not benefit of chest compression or putting tube inside his mouth if their heart stop. So I made the decision. So the next step will be to communicate this decision with either the patient or the next of kin or relatives.
All right.
So
Okay.
who's going to initiate this decision? So people usually don't understand this point. So DNR is a medical decision. It is not a wishes of the patient, but the way that we communicate this decision with the patient, we bring it to the table as a discussion rather than telling them that we came to the decision that we are not going to do the chest compression in case if the heart stops. So this is completely different. Patient who's going to die. So patient
Okay.
who's going to die, it is more of palliative care rather than the DNR patient, for which we are providing the full care of the DNR patient. The only differences will be that in case if the heart stop, we are not going to do the chest compression or putting tube inside the mouth.
Yeah. Yeah. I think regarding end of life care, probably we will need to do a separate podcast to discuss it in more details. Do you agree with that?
Yeah, definitely, because it is quite a broader topic and need more details, and it is yeah, it needs to have another session of podcast. Yeah.
Okay, so let's say that you came to conclusion that your patient, which we mentioned earlier, um, clinically for you, that uh, he requires a DNR form because of his comorbidities, because of his level of frailty, elder age. Um, Actually, I have a question. I want you to clarify it for me, if you don't mind.
Sure.
So, if we have someone who's elderly patient, let's say he's like in 80s or 90s, but otherwise he's in very good health condition. There is no major health comorbidities. His mobility is fine. He goes out and he does everything. Is age alone is enough to consider DNR, or it should be in combination with other factors which you mentioned earlier?
So this is a very very good question, and the good thing that you raised this point earlier, so we can make it crystal clear for our audience. I think the age alone, without significant comorbidities, it is not the factor that can make you come to the conclusion that this patient should be labeled as a DNR patient. I
Yeah,
think the presence of comorbidities, the frailty levels, and the previous hospital admission, a recurrency of admission to the hospital, those are the factor, plus the age, altogether collectively can lead us to the decision. But the age alone, without significant comorbidities, without significant medical background, is not sufficient to make a decision that this patient can be labeled as a DNR. Most of the people thinking that he's 80, no, I'm not going to do anything. We're going to initiate the decision of DNR. And I think this is not a right practice to be performed.
okay. And who's responsible to make these decisions? Let's say in the emergency department. Um, does it need to be like a consultant, or who can make DNR decisions?
I think the primary physician who is taking care of the patient, they have the right to make the decision. If the physician who's taking care of the patient is quite junior, he can just discuss with his specialist or the consultant. But anyone who is taking care of the patient in the ED, and he saw from his perspective that this patient was not going to benefit from DNR, they can initiate the decision. If the doctor is quite junior and have no practice before about this, he can ask for help from the senior one, either the specialist one or the consultant on charge. But it is not solely for the consultant, because sometimes the registrar or the specialist are covering the night shift, and there's no consultant on the shift, so they are the one who's going to initiate the decision. Or even if the junior doctor is quite had a good experience and he did this before, and uh, he saw from his own perspective that this patient is not going to benefit from the chest compression, he can make this decision. So it's a medical decision. Yeah.
All right. Okay. That's fair. Yeah. And can we fully resuscitate someone despite having DNA CPR form?
So the answer is yes.
Yeah. Can you explain more?
Yes. Let me explain more. Because sometimes we might think that this patient is going to benefit from the DNR based on the factors which we mentioned them before, but the patient came with a quite reversible causes for his illness. So the patient might benefit from short period of chest compression. For example, if the patient came with myocardial infarction and suddenly they went into VF, and we know that the chance of coming back is quite high, taking into consideration that we immediately commenced the CPR and we shock the patient. So it is quite reversible things. So the answer is yes. but you need to weigh the situation and what is the main cause of deterioration.
Okay. And I think there is many other medical conditions where we can just apply the same rules. For example, like if someone is coming with like anaphylaxis, so that's quite reversible.
Yes.
So I agree with you that there is a few medical conditions which are quite reversible, and we could consider doing full resuscitation despite having the NACBR form.
Yes.
Yeah. Okay. Um, so let's move a little bit and talk on the other side. So let's say that you've got a patient who's peri-arrest or just like went to cardiac arrest in the department, and you have no idea and there is no time to to check to see whether there is any escalation of care or any DNR form for the patient. Um, is it reasonable to start resuscitation and then be considered later on? Or, for example, sometimes it happens. They will say, actually, there is a DNR discussion started with the patient in the community, but actually there is no official document in the system or with the patient. So, uh, shall we do the resuscitation in these situations if things are not clear initially?
So yeah, so if things is not clearly initially, I think it is quite reasonable to give it a go and to initiate the chest compression, at least a gentle chest compression until you gather more information. I think will be harmless, and as well, if the next of kin are present, I think will give them more reassurance. And because yet it is the picture is not clear for you, and you don't have the clear history for you, and you just coming facing a patient in cardiac arrest. So while you are doing the chest compression, and at that time you can send one of the colleagues to have a look in the medical records, see what's the situation, what's the background, what's going on. At that time, you are doing the chest compression, and then the chest compression you can stop it at any point. Once you gather the information enough for you to make a decision of DNR, I think at that time it is reasonable to stop. But do not wait until you have the clear background of the patient or the general circumstances about the situation. I think it is quite reasonable to start the chest compression. Plus, as I mentioned, it will give more reassurance for the next of kin presenting. Because if you hesitated at that time to either to start or not to do the chest compression, uh, this will create a misrapport between you and between the relatives. And I think this point is going to stuck with them, that we didn't provide the optimal care for the patient. So I think it is better to give it a go. Maybe some people might not agree with my way of thinking in this situation, but I think, yeah, it is reasonable to do so.
Yeah, I do agree with you actually. And sometimes you might have a patient, for example, they have like a tattoo somewhere in their body and it's stating that do not resuscitate. Is that legally binding?
Uh, this is actually a very good question, but I think it is for me. I'm not going to consider it legal binding because to make it legally binding, I need to have an official document, either as an advance decision done by the patient in the past. That will be the legal document. But otherwise, just like tattooing, uh, I need to gather more information. I need to ask next of kin. But meanwhile, if the patient crashed in front of me with a tattoo mentioning do not attempt CPR, uh, I will just confirm that first before me taking that tattoo as granted.
Regarding those who are having DNR form, is there any like at any time they might be appropriate to go to ICU despite having DNR form?
Yeah, excellent question. So people think that when the patient got a DNR form, meaning that there is a ceiling of care, that this patient cannot go to the high dependence unit or the critical care, the ICU. So I think some people might still have a DNR and still will be able to go to the HDU or even to the critical care for receiving a particular treatment, which this treatment is not provided in other places rather than the critical care or the HDU. So the answer is yes. Some people might have uh, a DNR form in place, but despite though they're eligible for ceiling care to the in the critical care and the HDU.
All right. Okay.
Level,
Um,
level three, just like I will give you an example. For example, uh, a dialysis or uh, non-invasive ventilation, which cannot be provided in the ward, for example. So the patient might benefit from them in the critical care. Yeah.
okay. Yeah, because some hospitals they provide it in the medical ward, other hospitals they don't, and
Yes.
sometimes the patient could be quite unwell to go to the ward as well. So I do agree with you.
Yeah.
So let's move forward. And so earlier you said that before coming to this conclusion, and that your patient requires DNR form, you said that you are going to collect some collateral history from the patient, from his relatives, next of kin, from the hospital records. Let's say that now you came to conclusion that your patient is actually his best interest is to have DNR form. Um, how are you going to approach the conversation with the patient and or with his next of kin and or with his relatives? How to start that sensitive conversation with them in a way that's not gonna, uh, make problems. They have loved one who's quite unwell. They are quite stressed. So, how do you suggest to start these conversations?
Right. So yes, I'm going to speak about that. But if you allow me, I want to give a bit of details about the patient, the quality of the patient, or the factors which will tell us that this patient is approaching, or this patient might go into a critical situation, or patient might die at any moment. Is that okay?
Yeah, of course.
Yeah. So in terms of the situation when we are coming or trying to come to the conclusion that this patient we can label them as a DNR. So we need to check the trajectory of the patient. So in terms of the is the patient got terminal illness or the patient had an organ failure or the frailty score. So those are the factors which we mentioned them before. But there are other factors which we can see them, clinical signs and symptoms in front of us, which will tell us how bad the condition is. So if the patient is significantly agitated, despite multiple measurements, you've done it in the resuscitation room and patient is still agitated, or the patterns of breathing, the patient got shallow breathing, irregular breathing, abdominal breathing, patient is gasping for the air, significant reduction in the significant reduction in the level of consciousness, and patient is getting refractory bradycardia and then normal heart rate and then tachycardia, deep motile skins, noisy pharyngeal or respiratory secretions. All these are signs when you are seeing them at the bedsides. I think this will give you an idea about how bad the condition is, and this will give you more realistic situation about the initiation of the DNR and how bad the condition of the patient in front of you. And then based on that, you can make the decision.
All right. Yeah.
So,
Uh,
yeah,
yeah.
go.
Now continue.
And uh, if you want to add anything before me answering your question, that will be fine.
I wanted to say, addition to what you've just mentioned, if the clinical picture suggested that this patient might not survive this hospital admission until discharge, or the patient actually, because of the medical problems he's having, um, is likely to die in the upcoming few months, then probably it will be suitable as well to start these conversations. Do you agree with that?
Yes, definitely, definitely. Particularly based on the clinical signs which we just mentioned them, and combine this with the background of the patient. Sometimes we might have a sudden decline in the health, which is just like abruptly happen, and this is usually due to catastrophic intracranial hemorrhage, or patient came with major trauma with aortic injury. So those patients might be alive when you see them in the resuscitation room, but their uh, possibility for decline is quite high. And let's talk about the patient with terminal illness, like a cancer. Usually, they have a steady uh, level of care or level of health, but suddenly they might drop. And on the other hand, we have the patients with organ failures, which they have a gradual decline, like a patient who have a COPD and heart failure, and the situation is getting progressively worsening over time, but not abruptly like the patient who had a cancer, who had a stable condition, and then all of a sudden his condition quite dropped. And so those are the general situation which we need to keep them in our mind while we are doing resuscitation for those patients. Uh, Coming to your questions, now I came to the decision that this patient is not going to benefit from the chest compression and putting tube inside the mouth. So how am I going to communicate this finding either with the patient or with the next of kin? So this is quite sensitive talk, and you need to prepare yourself mentally before doing this conversation. And this conversation can be done only one time. So you need to either choose a proper personnel to deliver this conversation, or if you yourself are going to deliver this conversation, you need to prepare yourself mentally, and you need to choose your word carefully. Because if you lost the rapport with the patient or with the next of kin, situation might escalate, and then it will be difficult for you to grab yourself back into the conversation. So you need to prepare yourself mentally. If the conversation to the patient themselves, try to make sure that the patient level of consciousness is suitable enough to accept this information. But if you saw that the patient is quite agitated or the GCS of the patient is quite low, you need to make a conversation with the next of kin. If the next of kin is available with the patient, that's fine. But otherwise, if the patient came by ambulance and there is no one around, you need to look into the system and contact the next of kin, and do not try to break the situation by the phone. Preferably ask them if they can attend the hospital because their loved one is inside the hospital. If they are able to come, I think it is better to wait for them if the situation permit, the clinical situation of the patient permit, or the patient can wait until their relative coming to the hospital. So assuming that they are already in the hospital, and how we need to initiate this conversation. So it is quite sensitive, and I'm going to give you an example that you need to communicate this decision with the next of kin. So first thing, I'm going to prepare myself mentally, and then I'm going to invite them to the quiet, calm room in the emergency department. I will be accompanied by a chaperone. Ideally, I'm going to ask the nurse in charge to accompany me, and then once we're going inside, uh, I will start by asking the next of kin to confirm the relationship first, and then I will ask them, now your loved one coming to the hospital and my colleagues are taking care of him in the resuscitation. and then tell me more, please. What's happened uh, about today's visit, please? So they will start to give me more information about the general condition and the symptoms which started to appear, leading him coming to the hospital this visit. I think the first thing which we need to make it crystal clear, and it will be as a very good introductory point to the next talk which is coming through, which is a DNR. I will mention to the next of kin clearly that your loved one general condition is quite serious and they are quite sick. So will be the initial warning shot for them about what's coming next. So like this, they will be quite prepared. And here you need to be realistic, and at the same time, you need to be empathic, because you're going to deliver not very good news for the next of kin about their loved one. So initial warning shot that yes, you brought or your loved one came to the hospital today, and when we receive him, he's quite sick. I can give some details about this type of sickness which he got. For example, that he's not breathing properly, and his oxygen is low, and his level of consciousness is also low. And then I'm going to add it this way: they are very sick in the department now. Some people love to use that they're quite sick to the point that they might die at any point. So I think will be a good introductory point about what's coming next.
Okay.
Yes.
Yeah. Actually, this is really helpful. And I think the key that you've just mentioned, when you start this conversation, it's preferably with the patient himself, if his level of alertness is suitable for that conversation, preferably in the presence of his loved ones, the next of kin, family, if they are around. But if the level of consciousness is low, then we need to have this conversation with his next of kin or relatives. And that preferably face to face if possible. But if it's impossible, sometimes you might be forced to have the conversation over the phone. Is that something possible if the patient or the relatives are unable to attend to the bedside?
Yes. So we are facing this condition a lot. And so if they are not able to attend to the hospital, so before giving them any information, I want to make sure that they are okay, they are not driving, and they are in a good, comfortable position, so we can have the conversation. And I will ask them to sit down, making sure that there is no any hazardous while having this talk. And then I will start with them, telling them the information through the phone.
Yeah, we don't like to lose someone else. Probably if they are driving, that will be a big problem. So yeah, this is really important. Thank you.
Yeah.
Uh, and after you collected your collateral history from from the relative or from the patient, and actually, yeah, I do agree that telling them this is a critical situation and the patient is quite unwell and sick and he might die in the emergency department or during this admission. Um, so what's next after that? I guess we're going to tell them about everything we are doing at the moment. That's really important as well. So it will tell them that we are doing our best to help him to improve. Is that right? And to get to a good health, the point that they go home in a good health by the end of this admission. But if their condition deteriorated, so how are we going to, go to that discussion about DNR?
Yes. So I think you are right. And I'm strongly recommending that during this conversation, you need to make things crystal clear. And when you're giving the information, you need to break it very simple and very clear. And you need to be realistic. So we mentioned that in the mental preparation that this is quite sensitive talk, because sometimes when we're preparing ourselves just for only bad things or bad news, and this is lead us to forget about the good option or the hope which we can give it to them, because DNR patient is not going to die. There is chance that they might survive and they might respond to the resuscitation which we're providing now, and there is another chance that their heart might stop at any point. So you need to break this crystal clear to them. So after giving them the introduction that their loved one is quite sick in the emergency department, so I'm going to state it clearly that I'm here. I invited you today to talk about the management plan for your loved one. And so based on the condition for the time being, we are facing a very critical situation. So we have two options. We're going to hope that your loved one might respond to the medical treatment which we're providing now, but there is still chance that their heart might stop because of the significance of the illnesses itself. So ideally, if the heart stop, we are not going to do the chest compression. So here you don't have to have the pause after you mention this. You need to follow this by an explanation. So I'm here to talk to you about the condition of your loved one in case if their heart stop because of the illness. Usually we are doing chest compression to massage the heart or to revive the heart back. Sometimes we are putting a chest tube to help them breathing. But in the condition of your loved one, this will not happen. The reason for that, I'm going to give the advancement of the comorbidities or the presence of comorbidities, which led us to come to this conclusion. But at the same time, you need to make it crystal clear that there is a chance that their loved one might survive this illness. So you need to be realistic and you need to break the information crystal clear to the relative or to the next of kin. Some people prefer another way of starting this conversation. So they might ask their loved one or the next of kin, did the loved one had any wishes about what type of care he want to develop in case if the heart stop? Or did they make any decision in the past? Or did your loved one had this conversation before with anyone in the community or with the GP or with other doctors that what level of care they want to receive? So everyone is getting his own way. But the end result that we need to communicate this information very clear to the relative. And then after you tell them the information that the chest compression will not take a place for the situation of the loved one, followed by the explanation, followed by the comorbidities. You need to give them a chance to absorb this information which you just gave it to them. And then they will start to ask a question, or they might have points need more clarity. We need to give them the chance to talk and do not interrupt them. Let them talk. Let them express their feeling. This is very emotional talk, and they might start to cry, and they might have very significant emotions based on the information you just give it to them. So just please be empathic, give them time to express their emotions, give them time to ask their questions. And here, after giving this information, I strongly also recommend that you need to bring the brighter side for the situation, that there is still hope that they might go to respond to the medical treatment. And also here, strict advice to, after giving the hope, that you need to tell them that my colleague is taking care of your loved one, and we're providing them with the full medical treatment in terms of the, better to specify things here which are doing it now, in terms of the fluid, in terms of the oxygenation, in terms of the antibiotics, in terms of the any images will take a place, and the continuation of the care during this visit. Yes.
Okay. Yeah, this is a great explanation. Thank you so much. And I would just add, personally, my approach is not different from what you are saying. I usually start by collecting the collateral history and how much do they know about their loved one medical condition at the moment. And then, usually, when I start the actual DNR discussion, I start with question. I find that working really well for me. So I start usually by asking, did he or did she have any conversation before with her doctor about the future if her condition or his condition deteriorated to the point that their heart stopped? Did they have any discussion like that? And sometimes the relatives, they might say, oh yes, he had that discussion, or it never happened. So at that time, I would then tell them that actually, from medical point of view, we are providing the treatment at the moment, but we believe that if his heart stopped, um, then doing chest compressions and sticking tube in his throat is not going to restart his heart, and that's because of. And then I will specify the reasons why I believe that. For example, because of the comorbidities, because of the seriousness of the current medical problem, the frailty level, or combination of these factors. And also, I add, and even if we manage to restart their heart, it's highly unlikely that he's gonna, recover again and to his baseline level of alertness. Probably he's gonna end up in the intensive care for a long period, and then eventually he's going to die. So that's how I explain the situation, and why doing CPR is going to be futile. I would avoid particular words like uh, we decided, decision has been made. These type of words, I believe it might break the communication. So I would say our medical opinion, which is just the same thing, rather than saying decision has been made. I'm not sure whether you agree with me or not.
Yes, totally agree with you. The point which you mentioned it now, uh, I was about to talk about it regarding the vicious cycle, because they might ask you questions, so you don't know. Uh, my loved one is quite strong and he's a good fighter, and they might revive. You don't know. So this will be the answer because of the advancement of the illness and the body ability to compensate and to overcome this current situation. It will be lost because of the immunity, because of the frailty, because of the presence of the serious illnesses which is going on for the time being. Even though if he recovered or if she recovered, they might not come the same level as they were before the arrest. And so again, they're going into another cardiac arrest. So we're going to do the chest compression again. And again, they will come back, but not the same level as before the cardiac arrest. So it will be a cycle of suffer rather than bringing your loved one back. So it is matter of suffering, yeah. And regarding the things which you mentioned, that it is a medical decision, but when we are breaking the conversation, we, as you mentioned, we avoided to tell them that this is a medical decision and decision being made. We just came to inform you. So this is the actual situation is, but when we're having the conversation, we're not bringing the situation as just like this decision had been made, and we are informing you. So definitely, this is considered to be jargon, and you're going to lose the rapport abruptly with the next of kin. And remember when we mentioned at the beginning that this is quite sensitive talk, and this should be in the proper way should be done in the proper way and should be done once. And there is no chance here for correction or someone else coming to correct the mistakes done. So we need to break it more, obviously, with maintenance of the rapport with the next of kin as much as we can. And definitely they might demand or ask you to or request you to do the chest compression and putting the tube in. So you need to be more patient with them, and you need to understand their situation, uh, because it is a difficult conversation. And when they are requesting or asking questions or exploring their concerns, it's not because they are attacking you. They want to have more idea. They want to be convinced about your decision. So you need to convince them rather than losing the rapport by telling them that this is a quite medical decision. And unfortunately, Muhammad, I think this is quite common uh, condition that the physicians are telling the information just like this decision had been made, or we decided as a doctor that he's not going to benefit from this chest compression. And I think this is uh, not an optimal way for having this conversation, and definitely the end result will be not good, and things will escalate badly. I also recommend to put an example from your loved one. For example, me myself, I can tell them that if this has happened to one of my relative, I will go for that. So I think this will give them more realistic situation about the general situation which is going on, and they might believe you more that if you are in their place, you're going to take this decision. And you as a doctor, you came to the you came to the point that you are going to accept this decision for your loved one. So meaning that this is quite reasonable. We're going to think about this phrase in this way, which might help them to communicate this situation and the decision being made. So strongly recommend, as you mentioned, not to put it as, yeah, we made the decision. This is medical decision. We came to this decision. So all this considered to be quite jargon, and it will lose the rapport between you and between the next of kin or with the patient themselves.
Yeah, exactly. And the other point, which also I think we need to highlight, um, we should avoid putting the relatives in the situation where it is sounding that we are asking them to choose whether to resuscitate or not. Because, as you mentioned, it's medical opinion, it's medical decision. So we shouldn't ask the relatives or the next of kin to have that decision, because and it happens, by the way. So we need to make that clear to them, that actually it's medical decision rather, or opinion, rather than asking them to decide. Because if it's sounding like we are asking them to have that decision, and even if they agreed, yes, we believe he's not for resuscitation, actually those people might have problems. They might feel guilty afterwards. They might have mental health issues several months after this traumatic event, and they might feel that they did that. They chose for their loved one to die rather than to be resuscitated. So we should not put our patients or relatives in this situation. Obviously, if our patient he choose to have DNR, um, whether in the past when he was fine, or at the moment if their level of alertness is quite enough, then this is a patient choice, and we don't have problem with that. However, if clinically deemed that it's better to have DNR form in place for the patient, then we should make it clear to everyone, to the patient, to their relatives, that it's nothing about you. It's clinical opinion. Do you want to add something on this point?
Yeah, so exactly. So this the point about informing them about it is a medical decision. I will keep this me myself, this is my own approach. At the end of the conversation, after they understand the general condition and they asked their questions and they explore their concerns, and when I've seen that they've already accepted the situation, at the end I'm going to tell them that this is a medical decision. So my point is not to break it from the beginning, it is just like to keep it on the last. So definitely they might feel that they are the one who killed their loved one by their decision. So at the end, I will mention this to make it crystal clear for them that this is our decision, and I don't want you to blame yourself at any point. So it is the medical decision done by us as a doctor, because we saw the general condition, the comorbidities, and we came to the conclusion that he's not going to benefit from the chest compression. So please don't take any responsibility for this decision. It is a medical decision, but this is I prefer to keep it at the end once they have got the answer for their concerns and they got answer for their questions. So at the end, definitely we need to augment that with this information that it is a medical decision. Yeah. So because as you mentioned, if we didn't mention to them this, they might think that they are the one who killed their loved one, and they might live the remaining of their life with this feeling of bad decision made by them. So it is not it's not their decision. So this is I just prefer to keep it at the end after they explore their concerns. Yeah.
Yeah. I believe the whole this conversation, it's more of communication skills, and the verbal communication which we've been discussing now is really important, but also the non-verbal communication with the patient is really important. I mean, when having this conversation with the patient and or his loved ones, in particular when we speak to the patient himself, I think it's really important to put attention to our non-verbal communication. I mean, the way we are sitting or kneeling or standing beside the patient, if appropriate, holding hands, these small details, they might do like big difference. What do you think?
Yes. So this is very very important. I think this is play more important role than the talk itself, the behavior, your own behavior. So I think just like the best way to act or to communicate very well, it is just like to put yourself in the shoe of the next of kin in front of you, or to the patient themselves in front of you. How do you want people approach you? How do you want people to communicate with you in this situation? What level of empathy do you want to receive in this very bad moments? So I think if you put yourself in their condition at that time, you need to behave, or you will behave differently. So the posture, the sitting. So usually I'm just like sitting in the chair, leaning forward to them, and my full focus and concentration toward them. I'm maintaining with them good eye to eye contact. And sometimes I might just like stand up from my chair and sitting just like beside them in their chair, after informing them that I will come closer just like to support you. Or if they started to cry, if it is appropriate, you can just like give a gentle touch. You can just like share the information with them in a better way. Lean forward, have a good eye to eye contact, be empathic. It's not a matter of just telling the information and being without feeling. So you need to be more empathic with them. And sometimes I'm just like sitting in the floor, just beside their chair, supporting them. And in this situation, I strongly recommend to give them the hope, which is realistic. It's not faking, because still there is chance that they might respond to the medical treatment. So I think this is the best area for which we can bring the good news for them, that we're going to rely on this minor hope that they might respond to the medical treatment. So you need to be quite empathic. I think it is pure communication. This situation, and the communication is playing. I think, if I'm not exaggerating, I will give it 70 to 80% in this condition. How you are communicating with the next of kin or with the patient themselves, the behavior. So the nonverbal communication is quite important, and I think it is the larger proportion of the whole situation is about the nonverbal nonverbal communication. So I totally agree with that. So do your best and try to be more empathic and put yourself in the shoe of the next of kin or the patient themselves. Give them time. If they started to cry, just support them.
All right. And actually, sometimes people might ask, in particular, in situations where death is imminent. For example, if there is like massive intracranial bleeding or like massive aortic dissection involving the whole aorta, or similar situations where we know the patient is going to die soon. Sometimes, or most of the time, the family they ask, when is he going to die? I think we should have good approach to answer this question,
Yeah,
because if we say like in few hours, sometimes people might survive for a long time. So I wouldn't specify time period. I would say um, he might die within few hours or few days. It might take longer. We deal with human being, and we can't give specific answer to this. And the other thing, which also I believe it's really important, because sometimes they ask or they might think we're not going to do anything. So I would also strongly suggest to say, rather than uh, doing chest compressions, um, we are gonna focus and concentrate on making your loved one comfortable, particularly those who are approaching death. I know we are not talking about end of life care, but sometimes these DNR decisions and end of life care, they might interact, and some patients they are actually at their end of life. So we need to mention that we are doing something. We are going to concentrate to make them pain free. They are comfortable. They to control their breathing and this type of things.
yeah. So yeah, I think yeah, it is not the condition about the end of life care, but as you mentioned, sometimes they might come together. Making a decision of DNR, and the patient got this massive intracerebral hemorrhage, and so they came at the same time. So here you need to do both of things together. Uh, I totally agree with you about things which you just mentioned them, and it is quite important to uh, give them a clear idea about what's going to be next. And I strongly recommend here to mention clearly for them that we might apply some suction or respiratory secretions to make them comfortable. So, like this, they will be aware when they are sitting with their loved one in the room and the nurse is coming, or you yourself coming to do the suctions. I also strongly recommend to mention to the next of kin that we are going to provide some medicine. For example, if they are vomiting or if they got some pain, and this medication to make them pain free so they can be comfortable in their last moments. And sometimes we might give them continuous subcutaneous infusion or IV medication or oral medication just to make them comfortable. So you need to make that clear for them so they will not be surprised during these moments. And at the same time, you state to them clearly that they can stay with their loved one in the room. And sometimes we find it difficult to find a quiet room in the busy emergency department. So you can have a chat with the charge nurse to designate a specific area, calm area, or calm room for the patient to be there, and their loved one can stay with them. And some relatives, they love to be participated in the care of their loved one in their last moments. For example, doing the suctioning, giving them sips of water, uh, hold their hands, or to participate in any kind of care provided to their loved one in their last moment. So I'm going to offer to the relative, if they want to participate, to give them sips of water or to uh, just clear the secretions. So like this, they will have a sensation or feeling that they have done something for their loved one in their last moment. Uh, and the other point, coming back to that question at first, when they ask us about the remaining time. So here, my personal approach, I'm trying to avoid any specification of time frame as much as I can. I'm not even say either hours or days. I'm just going to tell them that it is quite imminent and at any time can happen. So without specification, because so it will be very difficult to estimate the time frame, and because as you mentioned, we are human being, we don't know. It might be within hours, it might be 24 hours, it might be 30 minutes. So it is difficult to specify time. So try to avoid specification of time frame for the imminent death as much as you can. I'm sure the relative is going to ask you this question multiple times, but you need to be realistic and try to avoid giving a specific time frame, because this is if things happen in the opposite direction, you might be in trouble. So just give it open, and but it is imminent at any time can happen. Yeah.
Yeah, fair enough. Um, Actually, I think this takes us to the last question from my side. Let's say that you've done the whole this conversation with excellent verbal and non-verbal communication skills. You've addressed all these important aspects of this decision. But if the patient and or his relatives or next of kin, if still they are not convinced with your medical decision, do they have the right to seek second opinion, or what shall we do in this situation?
So if I've noticed that the relative is still not convinced, meaning that either they are in the process of denial or my way of communication wasn't sufficient to convince them about the decision made. So I will start with exploring why you are not convinced, or please can you tell me why do you think that we need to make this chest compression? So like this, I will have an idea about the points in their mind, and I can have an idea about their concerns, and I will try again to convince them by any means, by being realistic and at the same time being empathic, because the denial process or the disagreement with the plan itself, sometimes it might be because of love. They love their loved one, that's why they need maximum effort to be done. So in this situation, I need to be more empathic with them, more realistic with them as well. So by asking them the question, it will be crystal clear for me. So my starting point for more convincing and communication, I can take a place from there. So assuming that they are still refusing and they want to ask for second opinion, so yes, it is their right. to seek a second opinion. So that's totally acceptable. But I need to be more uh, realistic with them in terms of telling them, yes, you have the right. So I will answer the question clearly. But at the same time, I'm going to inform them that the decision will not be changed, even though if you ask for second opinion or if you decided to take your loved one to another hospital, there the decision will be the same. I'm going to explore and add that by disconnecting your loved one from the medical treatment which you are providing now, transferring them to another hospital or asking for another doctor to attend. So this is just like might make the situation worse, but you have the right, and the decision there will be the same. So I need to inform them about this information. I think it is quite vital, and it might help them to accept the decision of the DNR itself.
Yeah, I think most of the time, if we approach this conversation with good communication, usually no problems arise at all. However, in really tiny minority of cases, things might, escalate, and actually, my family they might refuse, and actually, we might need to involve the hospital legal team, but that's really rare. Um, as you said, it's more of communication issues, and mostly will be solved without any need for involving any other, bodies.
Yes, I can add here as well. There is some religious issues behind the decision of the DNR and acceptance of the DNR. So we need to put that in our mind as well. So because in some religions, the decision of DNR is not accepted, so we need to consider that uh, into our mind while we're having this conversation. And because yeah, it is rare to happen, but sometimes it can happen that the things might escalate it up to the court. But I think it is at the end, it is a medical decision. So we shouldn't accept any forces coming from the next of kin or from the patient sides asking us to do the chest compression, despite though it is inappropriate to do this. So we shouldn't accept that if we saw it is medically inappropriate from the medical point of view. So there is underlying religious or religion issues, which is playing a part as well. But we need to do our best to have a good communication. We need to do our best to have a good rapport and to be convincing. And at the same time, we need to be more empathic with them. So I think as more empathy you are, or as more empathy you have, I think the communication will be much more easier by showing understanding and yeah, feeling about the condition itself.
All right. Thank you so much, Hassan. I think to wrap up this session of our Emergency Medicine Academy podcast about DNR orders in the emergency department, I think the main points every single time we receive a patient, we need to start our resuscitation as appropriate, and then collect collateral history from the patient himself, from relatives, next of kin, and or from the hospital records, and then start the discussion of DNR if we believe the best for our patient is to have that decision to be made. So we need to start by asking whether they had conversation, or uh, you might want to just mention the reasons behind your opinion, and then address all the concerns from the patient and or relatives. And good communication is a key. Good verbal communication, good non-verbal communication is the key for successful conversations. That's, I think, the big frame for this issue. Do you want to add anything, Hassan?
No, I think we wrap up just like as a reminder, uh, mental preparation, mental preparation, and then be empathic, and then try to have a good listening skills. Listen and then answer, and then explore the concerns. Be more empathic. Answer the questions. Be more empathic and be realistic. And yeah, and I think things will go well with you. Yeah.
All right. Thank you, Hassan. Thank you, everyone, for listening. Until we meet in our upcoming podcast.
Thank you.
Thank you.